This is the Neurosurgery Podcast. Welcome back to the Neurosurgery Podcast. Today, we are just delighted to be joined by Dr. Randy Bell. Dr. Bell needs no introduction. He is a titan in the field of neurotrauma and someone I've been wanting to have on the show for some time. I've seen Dr. Bell speak and got to interact with him at the University of Chicago TBI penetrating brain injury conferences that have been happening for the past few years here. And of course, we have to mention Ricky Ditzel, a great friend of the show who's been on a couple of times and was good enough to introduce me to Dr. Bell so we could get connected and get you on the show today to talk about, if I may, your baby, the new penetrating TBI guidelines, which have been finally brought to fruition. But Dr. Bell, I can't do you justice. Please take a moment, say hello to our audience.
Hi, everyone. Thanks, JP and Mike, for having me on. I have basically heard your guys' podcast over the years. This is really great. It's a real privilege for me. So thanks for inviting me. Appreciate it.
Well, that's great. Thank you so much. So, like I said, I want to dive right in because not to your level, not even to Ricky's level, but I'm kind of a nerd about this stuff too. I love it. I feel very passionate about neurotrauma in general and spinal cord injury, as people that listen to the show know about. But head to tail, trauma to the nervous system is a great passion of mine. And so let's begin at the beginning and kind of look at where things stood before it was decided to embark on new guidelines. So why don't we start with the old guidelines and tell our listeners a bit about what we had before this new set that came out and what care looked like for people with penetrating head injuries, say, 20 years ago.
Yeah, the old guidelines were published in the Journal of Trauma in 2001. A lot of really good stuff in there. Mainly dealt with the things that you deal with in the hospital pretty much every day. Infection, surgical management. There was some imaging guidelines. A lot of really good stuff. Half the document was dedicated to prognosis, which in the new guidelines, we took a different tack on. But ultimately, if you took care of penetrating traumatic brain injury, like I did at the start of the Iran-Iraq war, there was those guidelines. The downsides were they're not open source, so they're hard to find. And we were sort of, I think at the beginning of Iran and Iraq, we were kind of reinventing the wheel in terms of just how aggressive were we supposed to be? What the heck were we supposed to do? I mean, a lot of what had been done in Vietnam it's not like it had been lost, but it wasn't really fresh in the minds of anyone. And I think when I first started training outside, within the military, we had one paradigm. Outside, there's another. There seemed to be an overwhelming theme of nihilism, of non-intervention, of penetrating traumatic brain injury is, if not universally fatal, it's almost always going to be fatal. And I think over the years, that has unfortunately resulted in like a self-fulfilling prophecy. If you think someone's going to die, they probably will, because it means you probably won't intervene. If you think somebody's going to be paralyzed after a spinal cord injury and you don't do anything about it, well, they probably will. You don't know, though, initially. So that was sort of the foundation one of the foundations for why we needed to move forward, at least. That's what I thought. So.
Randy, that's a fantastic message. I love that. I'm guilty of being overly neurosurgery centric, and I tell people the neurosurgeon, anyway, is the perfect doctor. That we will get out of bed in the middle of the night, come right to the bedside, help people, operate on them, put in a ventriculostomy, take them to the OR, intubate them, whatever. And then as soon as things do truly look hopeless, unlike, I don't want to beat on oncologists, but like we're the first usually to say, hey, listen, this is been going on for a week and this looks bad, and we hang the crepe, right? Hang the black crepe. But your message is so on tune, and thank you for your service and the service of all of those who've been in the armed forces taking care of all these folks who've not only helped them, but also bring this information to us, right? Yeah. So with that in mind, what are the new data elements that are helping to formulate this? Is it just a refresh? Or is there anecdotal data from your experience, or is there actually new data that is getting incorporated that's sort of scientifically investigated?
Yeah, it's a great question, Mike. So this whole new idea started in about 2008 18 or 19 when I met with a guy named Greg Harlock. You guys may know is the primary author of the fourth edition TBI guidelines, and more of a giant in neurotrauma than I am.
Also on
Um,
the list, if he's listening or anyone who knows him is listening, please, we'd love to have you on the show.
I'll talk to him. I bet he would. So, but we met at the, I think it was the CNS in San Francisco, and we're like, hey, these guidelines need to be updated, and there is a reason why. So when we went back and looked at the literature, I mean, I had been heavily involved in publishing mainly on wartime traumatic data. I knew what that was like. But when you go back and actually look at the literature, when you do a basic literature search, put in your search terms through PubMed and pretty much every different search engine, what you're going to find is that about 70% of all the literature on penetrating traumatic brain injury was published after 2001 and the
Mm.
last guidelines.
Mm.
The actual body of literature is enormous. Now, that does not mean that it was super high quality, because it's not. And we can talk a little bit about what that looked like when we did the actual systematic review. But yes, there is a lot of new information out there. And I think the things that I sort of emphasize when I talk to folks and that the guidelines emphasize is, how we treat traumatic cerebrovascular injury, which I think is a distinguishing feature of penetrating traumatic brain injury when you compare it to closed traumatic brain injury. How we treat that is a real game changer. How we screen for that is a game changer, and then sort of how we intervene surgically. One of the more controversial components of the guidelines was we initially made a recommendation for if you decide to operate, you need to operate within 5 hours of the actual index event. That did not make it through the Joint Guidelines Review Committee for medical legal reasons, even though the data would support operating as soon as you possibly can anyway, at least from a level 3, level 4 perspective. So I don't know if that answered your question, but yes, there's a lot of new information out there.
Yeah, I mean, that is a great reason, obviously, to update and put out a new edition of these guidelines. We've learned more, and not just that there are more data, but those data being newer than the last guidelines means it's more relevant to modern warfare, modern injuries, modern medical practices, both surgical, anesthetic, and intensive care. So, if I could, and obviously this, I say the simple and obvious things all the time on the show. It's my job because I'm the simple guy. But listening to this episode is not a replacement for reading these guidelines. They are available in proof right now on the
That's right.
BTF website. They're available on the Red Journal website, and we'll link to all of this. There's incredible figures and tools and graphics that go along with this that are all available, and we'll link to that for the listeners. But kind of like when an author comes on to talk about a new book, we want to give you the perspective of the person who wrote it and helped to develop this, and also give you the really high level view. And so maybe we could dissect a few of the major categories where there are new recommendations that might change practice for people on the front lines, to make a horrible pun, taking care of these patients today. And so you mentioned cerebrovascular care, which I really want to dive into. And I know some of the other major categories are CSF leak repair, getting more aggressive with that. And then also maybe we can, at the end of this conversation, come back to just that aggression in taking care of these patients, turning away from the nihilism and being more surgically aggressive. But let's start maybe with the cerebrovascular care, because I think that's, as you pointed out, one of the most novel avenues to do more, to do new things with newer technologies we have compared to 20 years ago.
Yeah, well, I mean, that's my favorite part of the guidelines. I mean, I'm a fellowship trained, open endovascular neurosurgeon, and so I trained with a guy named Rocco Armanda. And when Rocco, first started at Walter Reed and the casualties were coming back, he was super aggressive, treated everything. And I think it made a real difference. Um, if you look back at the literature, there is only one prospective randomized trial in all of penetrating traumatic brain injury. That's it. One published
Wow.
trial came out of the University of Washington, University of Utah, looked at comparing diagnostic cervical and cerebral angiography with CTA. And the data are very clear. A CTA is not enough. You have to do a cerebral angiogram in patients with penetrating traumatic brain injury. And the recommendation that we were able to make was a level 2 recommendation. It's one of 3 level 2 recommendations in the entire document, that a diagnostic cervical and cerebral angiogram is going to be necessary for high risk penetrating traumatic brain injury. And that We define the high risk categories. That was one carryover from the prior guidelines, penetrating injury through high vascular concentration territories of the brain. Um, Really, that means pretty much everybody. And then, subsequent to the prior guidelines, you know, I mean, coil occlusion or endosaccular occlusion of aneurysms. I mean, that didn't really exist prior to 1991. The Guglielmi detachable coil was first and kind of came on the market in 91, patented in 1995. And so, when the prior guidelines came out, endovascular treatment was mentioned, but there wasn't really any literature to support it. And there is substantial literature that indicates and definitely supports, and quite frankly, in my own personal experience, you can put coil in what amounts to nothing more than a blood clot adjacent to a blood vessel, and it will shut down and it will preserve the parent artery. If you have ever operated on a penetrating aneurysm in the brain, what you know is that when you get in there, it's not an aneurysm, it is a bleeding blood vessel. And you can either sac that blood vessel if it's distal, or you got to figure out a way to reconstruct it if it's proximal. Let me tell you, that's not happening. I mean, you've got disrupted brain, you've got disrupted skull. It's not like operating on a regular saccular aneurysm that's even ruptured. The whole anatomy is disordered. It's just not the same. So ultimately, the endovascular approaches to the treatment of these aneurysms, whether before you operate or after you operate, is really, I think, one of the most critical parts of the guidelines.
Randy, can I diverge a little bit on topic because this is so interesting to me. Are you
Yeah.
saying that in the current military theater and maybe civilian too, that we are entering the era of like general surgery where someone comes in with a gunshot wound to the head and you don't even open the head, you're dealing with this endovascular as a more common routine thing? I mean, that's such a great idea.
Well, I wish.
Um,
But no, no. I mean, we're talking about just the traumatic vascular injury
I
consequences
see.
of that injury. Yeah. I mean, rather than the open surgical approaches to these traumatic aneurysms, I mean, so oftentimes what would happen is if you're going to operate on somebody, you prior to these guidelines, you might get a CT, you might get a CTA. And if the patient is coning or dying, you take them right away. You do your decompression, you get hemostasis, and then you basically bring them with CSF drainage to the ICU where you'd monitor them. A diagnostic angiogram, which is the gold standard, would then come several days later. The question was, do you take them back or do you treat them endovascularly?
But I don't want to get too far off topic, but this is
That's
so
right.
interesting because the endo guys have been saying for a long time, we're going to do everything. We're going to do the neurochips. We're going to do the tumors.
Yeah.
And maybe it is that we need some basic training even in the trauma theater or in, obviously in stroke, right? That a basic ability to be able to do something endovascularly might be something that's part of the future of neurosurgery. I mean, that would be very interesting to me. It'd be another growth area for us as a specialty, you know?
I mean, I would have absolutely no problem with that. I think that, well, Dr. Spetzler, Dr. Lawton, and others would not. And if you're listening, sirs, my apologies. But I mean, open cerebrovascular surgery is sort of on the downslope, endovascular is on the upslope. And I think that's kind of where the entire field is going. I think in residency, yes. I mean, you have to get catheter training now, just as a basic part of your neurosurgery training. But you're right,
Yeah,
Mike. That's sort of my thought.
and of course, thinking about the patients and the victims of these injuries, the more things that can be treated endovascularly, there are more people in the country available who are trained in these techniques. So that's good for everybody, even as we continue to train
Yep.
neurosurgeons to use these
Agreed.
techniques too. And so, we talk so much about spine surgery on the show because we have Dr. Wang, and I'm very spine oriented myself. So I'd be
Sure.
remiss if we didn't talk about the CSF leaks, right?
Yeah.
Which obviously are a very different animal in this context. But that was another major component about these guidelines is getting more aggressive in techniques to repair and control CSF leaks, which obviously are more prone to occur after a penetrating injury. So please talk a bit about that.
Yeah, so it's this one of the other of the three level 2 recommendations we were able to make was on CSF leak and repairing CSF leak to improve outcome. Sounds really straightforward. I mean, incidence of ventriculitis and meningitis following penetrating brain injury with CSF leak that's not repaired is as high as 30%. Outcomes are significantly worse when that happens. I mean, it's important for convexity injuries. The interesting thing, if you look at the literature, is there's not a lot out there in terms of how to repair penetrating skull base injury. And in any theater of war, because of explosive devices, that's what you're going to see. Improvised explosive devices. If you're near it, the blast goes up and it penetrates anterior cranial fossa, sometimes middle cranial fossa. When I was deployed, that was predominantly what I had to take care of. It's not like a closed traumatic brain injury CSF leak with a skull fracture. Sometimes we sit on those, right? We wait
Yeah.
for them to seal up. We don't divert CSF. It doesn't work in penetrating brain injury. You have to repair that. You have to treat it like a hole. And you go in and you have to basically throw the kitchen sink at it, get it repaired early, divert CSF, and follow very closely. If they end up coming up with an infection, that the outcomes are going to be they're going to be worse. So yeah, early repair, even if it's tough, if you can.
Yeah, well, Dr. Bell, like I said, when we land the plane, I want to give you room to cook and talk about the um, aggressive treatment that is. But before we get there, I think it would be interesting. You talked a little bit about the time to surgery, but since we have the opportunity to talk to you about the guidelines, and you've made I really appreciate you being so particular about what level of evidence you have for each recommendation. Is there something that maybe you couldn't put as high a level to the evidence for, or like the timing to surgery, there was some internal struggle with how strong to make the language. Any niche things that aren't on the billboard for these guidelines, but that you feel, in your opinion, in your practice, and your heart, are an important aspect of care for these patients that might not come through with someone just reading the document.
Yeah, thanks for that question. And yes, it is the timing to surgery.
Okay.
We went round and round with our peers at the JGRC, and I really appreciate their scrutiny. Um, there was a single study out there that actually looked at time to decompressive craniectomy correlating with outcomes. Based on our selection criteria, our inclusion criteria, the studies that we included had to be at least 85 to 90% penetrating brain injury. And this study was half closed, half penetrating. But it was the first study to sort of incorporate or at least take into account this concept of immortal time bias. Most of the studies out there look at survivability based on patients who arrive at the hospital as time zero. Really, you want to look from the point of injury forward. And in the
Hmm.
military, we were able to do that mainly because we know exactly when something happens. You've got corpsmen, you've got other young men and women resuscitating people under fire in the battlefield, and then they get to a combat casualty, a forward combat casualty hospital, and we know every moment of that time, so we could track it, and that's what we studied. And the results of that study indicated that your outcomes and progression towards death were significantly worse if you got your surgery 5.3 hours after the point of injury. We could not include that as direct evidence, but we utilized it to at least make an evidence based recommendation. And that really, I think, was, you know, to improve survivability, patients should ideally be operated on within 5 to 5.5 hours of their injury. Um, we had to remove any reference to time. And again, the medical legal environment in the United States is such that it was felt that if you didn't get there in time or you didn't operate in time, that could cause problems for folks. It doesn't change anything. The recommendation we had to downgrade, and we had to change the wording so it didn't include time. But that doesn't change. The entire discussion of the document still contains all that information and a hard drive. If you have somebody with brain coming out of their head, all right, and you're wondering, hey, should I operate? Let me put them in the ICU, maybe put a bandage on, and just see how they do until the morning. No, no. The main issue, and actually probably the most important part of this guideline, was it really came from an idea from David Okonkwo, who you guys probably know pretty well, and Deb Stein, who's a trauma surgeon at shock trauma at the University of Maryland. It's the idea of medical futility, and that if we can segue into the idea of how aggressive you should be, we're not asking folks anymore to make decisions about operating based on whether you think they're going to do well. I mean, if you look at from data from Track TBI and Jeff Manley, time and time again, neurosurgeons have proven that we are terrible at prognosticating. We are
Mhm.
not good at telling folks, at least with any degree of accuracy, how well you're going to do long term, except for when we decide that folks are not going to do well. If we decide folks are not going to do well, they're not going to do well, right? Because you're not going to operate and you will fulfill that prophecy. Number one cause of death in the ICU following trauma is withdrawal of life sustaining therapies. That's
Right.
what it is. And because of that, I think that the reason there's not more evidence, that prognosis section from the prior guidelines, I mean, it was good. It was an incredible feat of, of epidemiology. But what it did was it gave neurosurgeons numerous reasons to not operate. Every one of those prognosis guidelines were, basically things like pupillary dilation, age, multiple compartmental injury, et cetera, et cetera, et cetera. All these reasons to not operate. Oh, this patient came in and they're 70 years old. Well, we shouldn't do anything. Oh, this patient has, I don't know, bifrontal injury or transventricular injury. Well, we probably shouldn't operate. Right? There's all kinds of reasons to do that. What we're asking you to do is base your decision on futility, whether or not you think what you do will help. And we provide a futility assessment toolkit that has not been validated, but it achieved 100% consensus, and it gives reasons where medical futility is real. Things like penetrating brainstem injury, right? Through and through injuries through the brainstem. A patient who arrives bilateral, fixed and dilated pupils, and no motor exam, post resuscitation. Massive transcalvarial herniation. The whole brain is coming out because the whole side of the head has been blown off. Um, no flow on a CTA or black brain. I mean, these are the things that are really sort of straightforward. And any one of these can be considered futility. But if those things don't exist, and you think the patient needs surgery, you need to go. And if that's at 1 in the morning or 1 in the afternoon, doesn't matter. So
Randy, talk to us about how, I mean, you do trauma, you're passionate, obviously. All those neurosurgeons and neurosurgeons in training, right? Why should they care about trauma? So many people are like, well, I don't want to take trauma call, or I need to get paid for this. And I get that, the value proposition, because it's heavy duty. But tell
it's
us
hard
why
work.
you're passionate. Yeah, tell us why you're passionate about it.
I mean, well, I mean, it started, I guess, when I was really young. I mean, this is how my father died. My father was a Baltimore City cop. And he was shot in the head and killed in the line of duty in 1978. Our subject matter experts, you know, they were the ones that decided to dedicate these guidelines to my dad. I really appreciate it. Um, and sort of throughout my life, I don't know, it's always been in the background. And when I started in neurosurgery training, I mean, training at Walter Reed, I mean, I was there when the first casualty from OIF came back in 2003 April. I took care of most of these guys throughout my entire residency training. You can't help but just want to do for folks, and they're young. I get it, but trauma. I mean, what's the age demographic of folks with trauma? It's 18 to 40. These folks, may or may not be healthy, but they're young. They've got good physiologic reserve. If you just do something, chances are you're going to make a difference. And so, I don't know. I mean, yeah, it's hard. It's not as, I mean, I'm a cerebrovascular guy. I work in an environment now where there's only a couple of us in the entire state. I'm in South Dakota now. And so there's not many of us that do it. So my stroke call burden is pretty onerous. Um, but the trauma is still there. And, I mean, the other thing you guys may have noticed, I mean, trauma is, at least from a fellowship perspective, it's kind of a dying field. It's hard to get people to go into doing trauma and critical care fellowships for exactly the reasons you're saying. And so I don't know. I mean, it's also one of the parts of neurosurgery where we can still, there's so much we don't know. And if you're really interested in making a difference, this is how you do it, in my opinion. And it's not just the brain, obviously. I mean, spine trauma, let's face it. I mean, that's as if not more debilitating for patients if they end up with, paralysis below the level of their injury. I mean, if you're covering trauma, you're covering spine and brain most of the time. And so, you got to know how to do it all, and you can make a real difference. I mean, that's, I guess, what I would say.
Amen. Dr. Bell, thank you for sharing the story about your father. I remember hearing you tell that story at the last conference here in Chicago. What a beautiful thing to have these guidelines dedicated to his memory. We talk so much on this show in so many different domains about being aggressive. Head trauma,
Yeah.
spinal trauma and spinal cord injury, major deformity these days, new techniques for functional disorders, stroke and vascular care. We are
Absolutely.
getting more aggressive as a field across the board because, much like these guidelines, it's been 20, 25 years. We're better at what we do. The anesthesiologists are better at what they do. The ICU is better at what they do. We have better tools and techniques, and so we can be more aggressive. And it takes people like you and your colleagues and friends to shout it from the rooftops and give us something to stand on when we want to be more aggressive.
Yeah.
So, as we wrap this up, thank you so much for your time and coming on to talk about these guidelines with us and our audience. Please just take a moment and tell everybody where they can find everything, when they can expect it in their mailboxes.
Yeah. So finally, after multiple revisions, it's in press. Formally publishes February 14th, although you can find the proof still on the Red Journal website now. And then should mail February 16th. You should see the hard copy if you have a Red Journal subscription on March 1st. These guidelines are open source. So that means that even if you don't have a Red Journal subscription, you can access them and download them. And so anybody anywhere. So as you talk to folks, just let your trauma surgeon colleagues know. There's going to be an executive summary also published in the Journal of Trauma, which ironically is not open source, but nevertheless, our trauma colleagues get that. And so yeah, that's all coming. And the Brain Trauma Foundation has a website with all of these reference, including all of the other guidelines that have been done. There's also a web-based application that's going to be available to kind of help you walk through, acute rapid decision-making process as you work your way through the algorithm. That's the other part of these guidelines that's unique. It's the first BTF guideline that has been published where there is a treatment algorithm published simultaneously with figures how to do all of the things. I mean, again, because not many neurosurgeons operate on penetrating traumatic brain injury in reference or relative to the entire population. Maybe it's been a while since you've done it, and so the algorithm will, in a much quicker fashion, take you through how to do it. It's all there. So
Beautiful. We'll link our listeners to all of that. Dr. Bell, this conversation was long overdue, but what better occasion to have you on than to talk about this and the new guidelines? Thank you for your service. Thank you for you and your colleagues bringing us these guidelines and tools to our community and our patients. And thank you for coming on the show.
thanks, guys. Really appreciate the opportunity. It's great to see you.